So TB spine, a surgeon's perspective. So I'll discuss only the essentials and the principles of it in the interest of not repeating whatever has been mentioned before. Right. So, so nearly about 150,000 of new spinal TB cases are discovered every year, and it happens to be mostly in developing countries. So as we know, when you take the distribution of spinal TB, it occurs predominantly in the thoracic spine, just like cancer. So the reason being, if you take the sort of division of the spines, you have most of the vertebrae in the thoracic segment, 12 in number. Then also, so you have obviously most blood supply diverts to the thoracic spine. So cancer is more prevalent, and also TB is more prevalent in thoracic spine. And pathophysiology, it most commonly is caused by Mycobacterium tuberculosis, and hematogenous spread to the spine is a known mechanism of how it causes. So where it locates is very important, and it depends on the blood supply to the spine. So commonest place is adjacent to your end plates, or we call it the paradiscal location. It happens to be because the disc is devoid of blood supply, and we have mainly paradiscal arteries which supply the adjacent parts of the disc or subjacent to the end plates, and that is where we encounter tuberculosis. So I'll show you now diagrammatic distribution. So this is where the paradiscal space lies, if you'll be able to see it. So the disc is devoid of blood supply. So this is very important when we come to excluding other causes of pathology in the spines. So next places you can have non-osseous abscesses, which could be anteriorly, which tracks down along the anterior longitudinal ligament. I hope we recollect our anatomy. And it could be in the epidural space, which may cause cord compression, and it may cause neurological sequelae. And quite infrequently, you can have in the posterior elements, like in the pedicles and lamina, which may be a cause for significant instability. And finally, within the center of the body, which is called the central location. So that is where you can find. Clinically, now historically, we have seen that from the time of having symptoms, onset of symptoms, and to the time of diagnosis, there had been like a lag time of nearly about 12 months. It's a quite long period. But with the advent of new technologies to diagnosis, imaging techniques, now it has cut down to about 3 to 6 months. Still in our country, we see quite a long lag period because the patients are negligent from their aspect. So they tend to start with some constitutional symptoms, as you know, and virtually all of them, nearly 90 to 100% of them have back pain. And then pain tends to be more at the site of the lesion, and it could be central pain, like we call the axial pain, or it can be radicular in nature, which means that you get shooting pain or numbness along your legs and arms. So this could be due to like the pathological process causing disintegration of the bone, causing collapse and subsequent instability. And the neural elements can be compressed, causing back pain and radicular pain, and eventually it may give rise to pathological fracture. Now, as Sachini correctly mentioned, not all spinal TB needs to come to a surgeon. With the advent of effective chemotherapy, most of the spinal TB is managed by UHS physicians. So these are the complicated TB. So whoever develops neurology, obviously, the quickest way of relieving neurological symptoms and mobilizing the patient would be in some form of surgery, or if they have significant instability of the spine, or if they are developing deformity. So this is what we term as complicated TB. So it is when you have complicated TB that we come into picture, which will require surgical intervention. Now, it all depends on how early or swiftly we intervene. The longer the duration of pathological process, the more the destruction, and the more likely the patient will require a surgery. So why do they get delayed? Obviously, we have noticed with presentation, most of the symptoms and signs are quite vague. And well, not all of us have the access to MRI scans, and most of us tend to get an X-ray, plain X-ray. And at the initial stages, the plain X-rays are quite normal. So a lot of us with Pott's disease, we sort of speak about cold abscesses. So cold abscesses are another way of detecting whether there is, so it's a telltale sign of having an inside a spinal TB. So it is, why it's termed cold abscesses, it's devoid of inflammatory cells. It can be in the cervical region, in the thoracic spine or lumbar region. So they can either present it surrounding the spine or vertebral structures, or they can track along the parts of least resistance along the tissue planes and manifest close to the skin, like you may have a retropharyngeal abscess, or maybe in the axilla or neck in the case of a cervical spine. The thoracic spine, it may be tracking along the intercostal vessels, and you may find along the chest wall. And in the lumbar spine, you may have in the groin, in the form of a psoas abscess, or along, it may track along the femoral vessels, and it may be in the femoral triangle called the scar-pars triangle, or in the gluteal region. So this is a sort of a diagrammatic manifestation. So this is the petit triangle, or we call the region between the latissimus dorsi, the internal oblique, and the iliac crest. Okay, right. Okay, so for diagnosis purposes, the best form would be to culture the Mycobacterium tuberculosis in a tissue sample. As you all probably know better than me, it is not so frequent. On the other hand, we can have a reasonable diagnosis if we diagnose a typical granuloma in histological sample, if required, by staining with AFP. Plain X-ray, this is the dilemma. So we do perform quite a lot of plain X-rays. It can be quite novel in early stages. CT scan, non-contrast CT even, is a very informative tool that helps you even better than MRI scan. It helps you better to sort of detect the degree of bony destruction. So even with MRI scan, I would request for a CT scan, because that will tell you, so that's more specific for the bones, that will tell you whether there are any telltale signs that this spine is going to become eventually unstable, or whether this is going to lead into some form of significant deformity. Because all you see, as we discussed with the MRI scan, as you see in the MRI, you see increased light up with contrast in the vertebral body, like in the form of bony edema. But the disintegration is clearly visualized with the CT. But MRI is obviously the tool which we utilize for early detection. And you can use contrast as well. So using contrast will help you to exclude other causes as well. So we are in the form of detecting or excluding other causes like pyogenic, discitis, or most importantly, tumor. So MRI is helpful to detect any soft tissue involvement, abscesses, or any neurological insults. So if you go into this now, you can clearly see. So this is a contrast enhanced MRI scan. You can see the vertebral bodies adjacent are increasingly lit up. So that involves a significant bone marrow edema. So the end plates are destroyed in this diagram, but if it's not destroyed, you can clearly visually see that the disc space is not involved. So this is very important. I'll mention you why. Then along, you can see anteriorly along the planes or deeper to anterior longitudinal ligament. Okay, so it's spreading along deep to the anterior longitudinal ligament as an anterior abscess, or you also can detect behind it, there is an epidural collection as well. So this involvement of disc is very important. In spines, there is a terminology, we say good disc, bad disease, bad disc, good disease. So when we mean good disease, we mean pyogenic infection. So if the disc is involved in the MRI scans, we think it's pyogenic infection. And if the disc is paired, we think it's bad disease, which means maybe cancer. The exclusion to this criteria is tuberculosis. So tuberculosis pairs the disc. So this is where sometimes when the cases are inconclusive, doing a biopsy is becoming handy. That is where I can help you out with. So unfortunately, the interventional radiologists where I work, we don't have the tool, they do not have the tools to penetrate through the bone, the drills and all these things. So what we could do is we can get, with a stabbed injury, a tiny sort of a percutaneous method, we can get a biopsy from you under C-arm guidance. So visualizing through the x-rays with an AP and lateral film, we can pass a tiny trocar through. Patient may require site sedation or mild sort of an anesthetic, positioning him in a prone position. And by visualizing through the x-rays on an AP and lateral film, we can visualize the pedicles and we can pass the trocar through that. And once we've penetrated on lateral film, when we have seen that the trocar has gone sort of close to the end of the pedicle, we introduce a sort of a wire. And through that track, we can take multiple biopsies from both sides. So that's where I can be of help to you. Right. So now we discussed not all TB needs to come to surgeon unless if you need a diagnosis. Secondly, where we come into picture is when there is a complicated TB. So the main three indications that we operate are either neurological deficit, or if there is instability of the spine, finally, if there is deformity. Now, neurological deficit is obvious. So anybody coming with gross neurological deficiency at the time of presentation, or let's say while they're on ATT, they are developing neurology, or the neurology is not improving with your ATT treatment. So that's pretty handy. So this is quite straightforward. So it can be, well, neurological deficiency is quite obvious when the lesion is either in the cord level, whether if you have a lesion in the cervical spine or thoracic spine, less so with the lumbar spine. So causes for acute neurodeficit can be mostly it's due to mechanical pressure, significant breakdown, disintegration of the bone, causing instability. All these can cause pressure on the cord and cause neurological deficiency. So delayed ones can be if you have reactivation of the disease of the spine, or sometimes some people tend to have significant deformity, like in the form of kyphosis. And your spinal cord tends to drape forward along the kyphotic spine. And this may progressively cause a trauma to your spine, and they may develop a delayed myelopathy. Now, some people tend to develop acutely neurology that may likely be due to vascular phenomena. So what we know is when we discuss about prognosis for recovery, if you attend early, unlike other causes, neurological recovery is quite substantial with tuberculosis. So this is in contrast to what we know with traumatic causes, or if it may be even pathogenic infection or cancer. We always know any neurological deficit due to insult to the cord is time dependent. So the more swift you address and relieve the cord of its insult, the better the outcome. But in contrast, we see patients with tuberculosis who've been paralyzed, who've been bedridden for months. Still, after stabilizing and operating on them, we have seen them mobilizing quite early. So unfortunately, once the disease is resolved and they go into permanent deformity and neurological deficiency, the outcome of neurological deficiency should be poor. Now, what I need to emphasize a little bit more is the second indication why we've been referring is instability. Now, this term instability is quite loosely applied. What is instability? Now, when we take a spine, it is composed of multiple vertebrae, and it is one structure which, each component is important for its integrity. So in trauma, what we say is there are what we call stable injuries and unstable injuries. Unstable ones get operated, stable ones do not need any operation. So there are so many nomenclature how to identify instability in trauma. So that is the general consensus. So you assess whether the patient's spine is stable or not when the patient is erect on his physiological posture, when he's standing. So that is when, if you're standing and if the spine is collapsing to what it was before, that means the spine is unstable. So if it's collapsing, it will cause worse symptoms like worsening of back pain. It may compress your neurological elements and cause like shooting leg pains and numbness. And if you do an X-ray while the patient is standing, you may say it has collapsed more, it has bent forward or kyphotic, so this. But gradually they identified when you have a pathological cause of destruction of vertebral bones, the stability does not always go by the rules of trauma. So in the past, they have devised separate means how to detect instability in the case of spinal metastasis or tumor. And very recently, in 2023, spinal surgeon by the name Dr. Rajasekharan from India and a whole bunch of spine surgeons got together and came into this consensus about what constitutes or what elements are most important to say whether a spine is unstable in case of TB. So they call it the Delphi consensus. So these are the 5 elements they thought is most important. First thing is the age. So the younger the patient, more prone them to become susceptible to become deformed. Reason being, they have flexible spines. There's more cartilage than bone. Also, they have a higher disc content than bone. So they are more flexible and more deformity. And on top of it, they're still growing at the end place. Secondly, junctional. Obviously, cervicothoracic and thoracolumbar. So this is the part of the spine which is the transition zone between your mobile part of the spine and the rigid part of the spine. So mechanically, if you identify one part is mobilizing, the other part is rigid. So at the junction, you may tend to have more force and hence deformity. Then you can have deformities in the form of kyphosis, which we discuss a little bit, and how much of collapse of individual bone has happened. Finally, they define certain things as on a plain X-ray, what are spine at risk signs. So from kyphosis, so Well, why do people develop kyphosis is simply because when you consider your sagittal balance, if you stand erect, spine tends to sort of be in a very straight line. So if you have a sort of and a center of gravity tends to be sort of tipping forward. So if we have any disintegration of the bone, it's always try to tip forward and cause a kyphosis. So you draw a line parallel to the above and below vertebra, and if it's more than 30 at the intersection, it means a significant kyphotic deformity. Same, you can also assess how much of bone loss it is. So on an average, if there is more than half of the bone is lost, and if there's more vertebrae involved, that tends to be unstable. And then there is certain signs in a pre-op X-ray which they detected, which may be prone to instability, especially in kids. So these are called spine at risk signs. So based on all that, they sort of gave a score each, and the total score being 9. Anything beyond 3 will constitute an unstable spine, which requires surgery. So the third reason is deformity. As we know, 95% of the TB involvement is in the anterior column. So anterior tends to get disintegrated. So there are terms which we refer as what is a knuckle deformity. That is when one vertebra is involved. When 2 or 3 is involved, we call it a gibbous. And more than 3 is involved, we can call it a global kyphosis, anterior kyphosis. So the thing about deformity is in adults, once the acute stage is relieved, the deformity does not progress beyond that. In contrast, but in kids, even after the acute stage is concluded, the deformity can keep on continuing. So in children, they have estimated that about 40%, even after the disease is cured, they may progress into deformity. So who will progress in kids? Again, we can utilize what we call as spine at risk sign. So all of them, once they are destroyed, once the acute disease is progressed, they tend to heal. Some heal uneventfully without significant deformity. Some go on to cause significant deformity, especially if you have multiple bones involved, a lot of facet joint dislocation at the back. They can even go on to becoming horizontal, especially in the form of the third form, which is shown here. It happens quite often in kids. Now, what happens in this is they are still growing. The growth happens at the end place at the top and the bottom, which we call the apophyseal rings. So when this happens, they grow into your canal. So these are the subset of people who can develop delayed neurology, and myelopathy may require some intervention. So we have discussed, so you can have various indications for surgery. It may be with neurological deficit, without neurological deficit. The ones we have not touched upon is like if you have a large paraspinal abscess, which is not remediable with ATT, which is not resolved, we can still operate. Or if you have a paraspinal abscess, which is causing like a significant impact to his life, like respiratory distress, that will be helpful for us to drain. Okay, so what are the goals of surgical management? Firstly, to drain whatever the abscess we have and remove all the infected tissue and debris and cause surgical stabilization. Now, this term surgical stabilization is very important when it comes to infection, wherever there is break of bone. The reason being is if you have a broken bone due to natural cause, a pathological cause, the more there is movement at the bony ends, there will be constant irritation of soft tissue and chronic inflammation. That will be a very good culture media for infection. Even in the case of pyogenic infection in the spines, if it's not resolving, now we go on to stabilize the spine. So finally, if we help to operate on this, it will prevent the progression of deformity and neurological recovery could be quite quicker. And also this helps us to get some histological diagnosis. So there are various ways we operate. We can go from the front, from the back. So universally what we do is, so commonly what we do is, if you take thoracic spine, going front and back is very sort of like it's a big trauma to the patient. We tend to all go from the back at the moment. So what we do is so this is called a screw, like carpentry. So we tend to put screws, and this is the workforce of thoracic and lumbar spines. So we tend to put screws to the vertebra above and below, and we take the whole back segment off, the spinous process, the lamina, the transverse process, and we also laterally dissect, and we can take about 2 or 3 ribs off. So this will give us good access to the front and do a good debridement of whatever is in front. And also we can put even a rib or some form of like a cage or metal thing in front, which will give a good support from the front and back. So you can go from, so these are some couple of cases I thought I will discuss with. This was a 51-year-old lady who, like about a few months we operated. She presented to us with bilateral upper limb and lower limb weakness. So for 3 weeks, and she was completely mobile and she has lost sphincter control. If you look at the CT scan, you can see the C4 is completely disintegrated, more than half of it's collapsed, and C5 end plate is destroyed. And you can see the bone is encroaching into the canal, which we call retropulsion. And anteriorly also, you see there is a lot of space, which is seen as an abscess in the MRI scan. So what we did was we can go from the front, we can evacuate whatever the content is inside, take off the C4-5 body, and relieve all the pressure on the spinal cord. And once it's visualized, we can put a sort of a metal graft, the metal sort of cage there and support it. This is one last case. This was it. So that was neurology and instability. So this was a 32-year-old gentleman who was on anti-tuberculosis treatment for 3 months. He had unremitting back pain, but no neurological deficit. Progressively, the X-rays seemed to be deteriorating, and he was developing a kyphosis. So maintaining the back lordosis at the lumbar spine is of utmost importance. That is the most biggest interest in the world at the moment. So you can see the L4 is completely destroyed. It's called a vertebra plana. On the MRI scan, you can see on the axials, there's huge abscesses on the psoas region, and the chordae equina is completely effaced. Sorry if I don't know if you can visualize or not. So it's completely effaced. So in this case, again, we can, without going from the front, all we did was go from the back. We again utilized the screws to the top and below vertebra, completely resected whatever was in the back, isolated the L3 and L4 nerves, and took whatever the sort of drained all the abscesses which were in front and all the debridement, and put a cage in front to stabilize it. So these are what we can do. So hope I didn't bore you much. Thank you. That concludes my speech. Thank you.